Thank you, everyone. Thank you all speaker for that very stimulating keynotes. Really appreciate and keeping on time, more importantly. So just to summarize this session, I would like to say briefly that we have taken some keynote messages from these talks. CERA and iCare are evidence-informed policies and strategies, putting lived experience at the center. Yeah, sure. Actually, putting lived experience at the core of the policy, collaboration and partnership for all three organizations are the core business with other industries and research partners. And from Professor Ashley Craig's keynote on how evidence is enhancing our knowledge and influencing future research and clinical implications. So now the floor is open for question and answer session. So just wanted to recall if few people have joined later on, people in the room, just raise your hand and one of our coordinator will come to you, pass you the mic. You can ask the question to the panel. People online, they can just put the name of the speaker, put the question, and our online coordinator, Dr. Kishan, will just read out those questions for me. Okay, so maybe we can take one question. Komal. There. Thanks, Komal.
Hi everyone, my name is Komal. I am from the Agency for Clinical Innovation in New South Wales. And I've also had the privilege of working for NDIS and iCare. So my question is for Sarah. Look, I just wanted to say I commend this new model of service delivery because I can see benefits for tailoring the intensity of care delivery for people who need it. But I can also see benefits from the staff point of view because I can imagine that the job satisfaction will increase because they have the time and the resources to actually serve people who need more care. My question is really around how flexible is this model? Because for want of a better word, once a participant is pigeonholed into a certain category, life happens, as we saw from Dr. Craig's presentation. And people can move from one category to another. So how often is this assessment done? And is there scope to reclassify people?
Thanks for the question. And good to hear you've worked at both the NDIS and iCare. That's a good combo. But definitely is the answer. So the way in which the model works is that the characteristics that are looked at regularly, and it is well known that people will move through the different levels. Not dissimilarly to the model at the NDIS, where people are in the general or the supported, the complex or the very complex groups, and we're able to move in between depending on how circumstances changed. To some extent, I think it's a little bit easier at iCare. There's 2,000 rather than the more than 500,000 than at the NDIS. But definitely we expect that they will move between the groups as life events change, and we will be able to respond accordingly.
Thanks, Komal. Thanks, Sarah. Maya, Ian, on the back.
Good morning. Thank you very much, speakers. My question's for Lauren. We're in a very difficult situation with reference to workers' compensation, clearly in New South Wales, with costs, but also the impact on injured workers. Could you explain what CERA's role is going to be in trying to resolve the current issues?
Thanks for that question. I'm the AD of the CTP scheme, not workers' comp. No, you would obviously be aware that there is a bill before Parliament at the moment, so I really won't comment on that in terms of government processes and whatnot. But I think any response from industry and from the regulator specifically needs to be multifaceted, and it needs to respond to the specific risks within the scheme. So we are seeing obviously increased average claim sizes around treatment and care, or reasonably necessary medical expenses in the workers' compensation scheme, and we're not necessarily seeing the outcomes attributed to that, because obviously if treatment costs were going up and that was aimed at all early intervention and facilitating care early, and we were getting better than return to work outcomes, then brilliant outcome for the scheme. So there's a lot of focus at CERA on that low value care and how is that in the scheme. Is it low value care? Is it leakage? Is it fraud? And then trying to go after that. So we've recently engaged Sue Dawson, who's the Healthcare Complaints Commissioner, to come in and do a strategic review of health provider regulation, and looking at what our action and response will be to that. So really working across government at both Commonwealth and state to better co-regulate in this area. It is a highly regulated, health providers are highly regulated, depending on, what sort of provider they are. And we really need to work better together, because I think collectively it's known that, the regulation in this space isn't really having that level of impact. So really looking at that co-regulation and improving some efficiencies there, the policy framework, so the frameworks that enable the care in the scheme, we're reviewing those to understand how we can drive better person-centred care through those, and then we'll have an operational response to that, so going out and supervising and enforcing that with our insurers and with our providers to make sure that they are doing the right thing by the scheme and meeting those scheme objectives. So I think for CERA, putting aside the bill, I think the biggest opportunity for impact is in that health regulation space.
Thanks, Lauren.
Ian, it's a really interesting question. I'm just going to jump in. Sometimes when you're in the position that I am or Lauren's are, and you're looking at the trajectory of some of these claims, what, as you as a researcher, do you think you would do differently in terms of the models of support you might put in place?
Thanks very much, Sarah.
That's okay. For those that don't know, I started my career at PricewaterhouseCoopers, and one of the very first projects I ever worked on was looking at whiplash injuries with Ian, so he has known me for a very long time.
Just very briefly, I feel I need to understand the issues better. I don't understand the underlying factors involved here, what's generating the increased costs, and then also I don't understand at the moment the extent of low value care. It's inevitably occurring, but yeah, so as a researcher I need to know more first.
And we've just recently wrapped up a low value care research piece through, I'm going to get this wrong, is it Melbourne University, Heath? So Heath Noy up the back is our Manager of Research and Translation, and that's given us some real insight into the low value care in the scheme, so we'll be doing work with industry in response to that, and that'll come out soon.
It's probably an opportunity though, if we think that the research community doesn't have enough information to be able to better understand the issue and advise, then I think we can think about how we improve that.
Thank you. Can I just ask my online coordinator if there are questions from online audience? So one question. Yep, okay, thank you. Over to you, whoever the first Candice. Thank you.
Hi there, Pip Elder from OT Rehab Consulting. Primarily I work in the CTP space, so Lauren, my question is probably more directed at you. From the research, it really does sound to me that preventative, intervention is going to be really beneficial, especially within motor accidents, injuries. I guess my question is around the scheme and particularly the guidelines. Do you feel like the guidelines really do support, preventative intervention in terms of, some of the insurers being able to, support and also approve such interventions within CTP?
It's a great question. So we recently, so I assume you're referring to the motor accident guidelines. So we recently reviewed those in consultation with industry to just do a reset and really ensure ourselves that the obligations that are imposed on the parties through those guidelines are evidence aligned and will lead to the best outcome. So there's been a lot of work done in terms of identifying, those provisions that were potentially a barrier or wasn't facilitating the right behaviours within the scheme. But really the guidelines at the moment around insurers is they basically need to intervene early, they need to risk assess early, they need to come up with an action plan or a recovery plan to respond to those risk identifiers, and they need to put that into place, and they need to regularly review those risk identifiers and to make sure that the plan is current and person-centred, which goes a little bit to Sarah's point earlier about that regular review. We know that recovery is not linear, so the obligations placed on insurers is really about that person-centred approach in the guidelines, as well as having the customer service conduct principles in place as well, which really drives the way in which they engage to do those things. So I think as a regulator, we're comfortable that those obligations are right. That the insurers, as I sort of mentioned earlier, the insurers that show that more person-centred approach and are more compliant to the guidelines are better performing in terms of outcome measures and profitability measures. So it's just about continuing to lift all of industry up together.
Thanks, Lauren. The person in front. Yep, thanks. Thanks, Candice.
Thank you. Kate Moore from Moore Rehab. My question's for you, Sarah, just in regards, my team are dealing a lot with approved case management services for the severe injuries in eye care, plus CTB care as well. And I guess what we're facing, we're often identifying and flagging very early some of these risk factors for psychological concern and injury, and trying to manage that as best we can proactively. And with some changes to social work frameworks in engaging social workers to assist us as case managers on the ground, dealing with post-incarceration social issues, which are really tricky as a case manager to deal with. I guess we're facing a lot of challenges on the ground, and it makes our job very tricky to try and implement services proactively to address these issues if we don't have those services. And I guess, I know it's a hard question, but I guess how are we reviewing that framework of engaging and getting assistance for case managers to address some of these issues so that we can minimise the trajectory of injury and the psychological issues?
It's a really good question, and I'm happy to take it away and have a further discussion with you to understand it more and work on how we can look to resolve some of those issues. I don't have anything at hand that I can share with you. A lot of my NDIS experience, I did understand this need for the supports in a range of different other services and how you brought all of that together. And it was very tricky across lots of different systems. Potentially with eye care, we might have a slightly different funding model, which makes it maybe easy to bring some of those services together. So I think it's worth a broader discussion. Thank you.
Thanks.
Thanks, Sarah. Kishan, you want to ask the online question now?
One question from Sylvia Gustin, a colleague. Wonderful talk, Ashley. Truly great breakthroughs. I'm wondering where you think emotional dysregulation fits in. In pain management, we know that people with chronic pain often experience emotional dysregulation, meaning difficulties generating positive emotions and dampening negative ones. Question: do you think emotional regulation could also be a treatment target in spinal cord injury rehabilitation, perhaps even in the preventive space?
Certainly, that's the case. In fact, the clinical trial we're running, we believe we are addressing emotional dysregulation. We're doing it through regulating the autonomic nervous system. A little clue why we went that way: when the Ministry of Health released their funding goals, they said we will not fund mental health. So that sort of set me back 2 paces. But then we thought, well, okay, let's get in the back door and look at other ways that can affect mental health. And so emotional dysregulation really is a bottom-up, top-down issue. So bottom up, meaning sensory information in, pain, smell, sight, anything that you might experience anywhere, even unconsciously or subconsciously, perhaps a better word. So a smell might be associated with a particular event, and it just sets off the bottom-up sensory information going in, sets down a top-down, meaning a cortical top-down type bias, like catastrophizing in the worst-case scenario, dysregulates the function of the brain. So we're just producing a paper. We've just submitted that paper at the moment to the Journal of Pain. We believe this is a really important focus of future research. So yeah, I think it's got huge impacts or potential for spinal cord, but as I tried to show, mild to moderate certainly also.
Thank you, Sylvia and Ashley.
Thank you, Sylvia. I owe you $50.
Thanks. Back over there, Rohit.
Cash for comment or?
Yes.
Hi, good morning. Rohit Mandana from iCare. My question is for Ashley. It was fascinating to hear about the breakthroughs you're mentioning. And so this is in relation to the breakthrough on catastrophizing. I think from what you shared that there's increasing incidence post the 12-month period. But also from research, we know that improvements plateau around the 2 to 3 year mark with brain injuries. And so I'm just curious to understand, is any research on, as we see plateauing in improvements and the increasing, how might we address the increasing catastrophizing post the 12-month mark?
Did you say in brain injury?
Yes, yeah.
Right. Graham Simpson. Sitting up the back there, do you want to answer that? Like I do a lot of research in mild brain injury or mild TBI, but Graham is our local resident expert in moderate to severe. Graham, do you have something to add to that?
I don't think there's been a lot of research in the field done in terms of the role of catastrophising and how that might contribute to psychological distress. But we've just actually released some national clinical guidelines for best practice in treatment of mental health. And there's certainly a growing evidence base in terms of a range of effective psychological treatments and interventions that both enhance wellbeing and reduce levels of psychological distress. Some of these things are multidimensional and you can kind of tackle it from lots of different kind of angles, and also I think there's you can tackle it from different angles, but also I think we can find the intersection between resilience and catastrophising is really important. And so I think we need to understand more about the role that it might play. We have treatments that I think, even if they don't tackle it directly, we're seeing a significant improvement. But we're still, I think, very much on a learning curve with this.
Of course, in a future session, Diane here, sitting up the front, is talking on TBI. Do you want to comment, Diane?
I can.
I think CBT interventions definitely address catastrophizing thoughts, and we have found that CBT can be quite effective, but I'll be talking more on third wave therapy. So it's not that we specifically have examined catastrophizing thoughts in the research, but definitely a component of CBT is looking at your thought processes and those catastrophizing thoughts. My life is over, or, you know, no one's going to want me anymore, or I'm stupid, these sort of thoughts then that will lead on to psychological distress. I should face this way, face the crowd. But anyway, I'm going to talk more about third wave therapy, so hang around and listen to the latest research and, you know, where we're moving in psychological treatments.
Thanks, Diane. Thanks, Ashley. Thanks, Rohit. And Brian?
But perhaps we've raised a big issue. We need to do research in TBI and catastrophising. Graham? Let's talk about it.
Thanks, Ashley, yes. Lisa, like Candice, Maya, one of you. Thank you, Lisa.
Thanks. So I'm Lisa Harvey from John Walsh Centre. I'll declare my biases, namely I'm a physiotherapist. But, you know, one of the things I keep thinking about in terms of the solution here, like if you think about who is our workforce, particularly post-discharge, you know, a lot of our workforce are physios and OTs. And so perhaps the solution here is better equipping our physios and OTs to be able to address these psychosocial issues, and also not to undervalue what just regular physical exercise and therapy does in terms of building people's, you know, sense of hope for the future. And maybe some of our physical interventions and OT interventions aren't so much actually helping the physical outcome as such, but perhaps what they are helping is people's sense of hope for the future. And I think maybe that might be part of our solution here.
I agree totally, Lisa. One of our projects in spinal cord injury, in fact, is increasing the awareness of psychosocial issues in the multidisciplinary teams treating or managing spinal cord injury in our hospitals. So probably you could add nurses to that. Yep. There are very few psychologists like hen's teeth. But yeah, look, I totally agree with that, and I think that's one way forward we should look. And in fact, Trudy Rubeck is talking about how to do that in the last session, offering some advice on how the multidisciplinary teams can help reduce psychological distress.
Thanks, Ashley. Scott?
Hi, Scott Dickinson from iCare. I couldn't let the session go by without asking about artificial intelligence.
Yes.
This is for Ashley. I'm just wondering, Ashley, what your thoughts are about artificial intelligence and supporting participants, psychological support for participants. So, for example, there is one organization called Leap Forward who have developed a chatbot for exactly this, and there's a paper actually that's been released with this, and it proved quite effective actually, and I think it looks like it helped some people. This is for people in a workers' compensation scheme with injury, and it really helped them to return to work. It seemed to increase work readiness and return to work. So yeah, I was just thinking about what you were saying with regard to catastrophizing and all of that sort of thing. And I could just imagine if there was a chatbot that worked well and was tailored for such a thing, it might be really useful. Anyway, interested in your thoughts on that.
Do you want to fund that? I agree, and AI has huge potential and is exciting as long as it's getting the right information, and I think that's the critical issue. But I think anything that could help people to not catastrophize, ruminate, for instance, or magnify the effects, or feeling helpless, they're the three domains of essentially of catastrophizing. And of course, it's worry. Catastrophizing is a big word, literally, but it's really extreme worry. And if AI can be shown to help in any way, of course, we should pursue that. Yeah. Thank you.
Thank you both. Lisa? Candice? Thank you, Candice.
Sorry to go again, but you know, some of us had just come back from the International Spinal Cord Injury Conference, and one of the big things that's happening in Europe that I think is having a very big effect on psychosocial following spinal cord injury is what is called active rehab, where people with spinal cord injuries are partnered with mentors and they live together and they learn from them, and it's all about trying to improve their resilience and ability to cope with spinal cord injury. And I see that as a really big opportunity here because it's so big in Europe and so successful. And I think, why aren't we doing it here?
That's an interesting comment because I think you're going a lot there to peer support. There's a lot of evidence of successful peer support models in the disability space as well. So it'd be good to explore.
Thanks, Ashley. Anything from online? Kishan?
Question for Ashley. If you can please provide a bit more information on the intervention undertaken in the 5 weeks to change breathing.
We're referring to the spinal cord study that I showed some of those results of here. Of course, that was an amazing result, and we don't always see that. But essentially, based on the fact that spinal cord injury does result in dysfunctional, at least an imbalance in the autonomic nervous system, for instance, problems with the sympathetic arm, which cause huge problems down the track, and will be related to mental health issues, resilience, and so on. So what we do is we actually train, we educate strongly about a number of issues in that trial. So self-education is hugely important, we believe, so they understand their body. Like in my own practice, because I'm a practicing clinical psychologist, mostly in the field of injury, by the way, lifetime care, CTP. One of the few who still want to do this work, which is a problem, I think, for work cover. But so we educate, we then go into the relationships between the autonomic nervous system, breathing, the vagus activity, the parasympathetic activity, how to stimulate that. So there's a lot of education going on. And then we start training them in resonant breathing. So that's getting your breath rate down. And each of you sitting here have a unique resonant breath rate. That will be between 4 and 7 breaths per minute. And when you get to your resonant breath rate, which we can determine in our lab in Royal North Shore, then the resonance between heart rate and breath rate, as you saw in that figure, is optimal. And then it seems that healing occurs much more optimally, much more, it hugely boosts physical resilience, for instance. So we train them and we send them home to use these skills. We also train them in other psychological strategies like mindful strategies and so on. So these are the strategies that we use in that trial. Yeah, I can go in much more depth, but
Thank you, Ashley. I think